Good morning, everybody. I'm Melissa Negrin-Wiener, co-chair, actually chair of the Health and Wellness Committee. Would love a co-chair if anyone's interested, of the HIA. Today I'm coming to you from my home because true to topic, I have somebody with COVID in my house. We are really thrilled to have Dr. Sharon Nachman from Stony Brook with us this morning. I'm going to let her get right into it. Please, if you have questions, type them in, and then we'll take them at the end. But just type them in as we go. If you have questions, that would be really helpful. And Dr. Nachman, please take it away.
Okay. So good morning, everyone. Make sure your phones or computers are on mute so there's no background noise. If you have questions during the talk, please type them in the chat and then we'll go through the questions at the end. So it says people waiting to be admitted. I'm hoping you're doing that. I will share my screen and minimize this and do this. And we should be okay. So this morning, I thought I would talk a little bit about COVID, everything you wanted to know, but we're afraid to ask. What we're going to talk about this morning is a bit about the virus and the vaccines, some myths, some truths, a bit of question and answer. I have no conflict of interest. I do not get any funding except from the NIH, and I'm funded by 3 different institutes. I serve as the PI of the Impact Network, which focuses on developing clinical trials for pregnant women and children across the world. So really, let's start a bit about the virus. This is an RNA virus, and this is the family tree of RNA viruses, and they come in a whole bunch of different flavors. There are the single-stranded ones, the single-stranded negative sense, and the double-stranded ones. And the further you get away from one type of virus to the other, the less similarity between those viruses, and the less that your immune system, who has seen one of those viruses in the past, will make a good immune response to the new one. So as you can see, the SARS-CoV-2 near the blue arrow is coming down from the SARS-CoV original virus, then MERS, and then SARS-CoV-2, which is what we have now. So they are somewhat similar, but sort of far enough away that antibodies for one really doesn't protect you from antibodies from the other ones. So let's talk about those antibodies and how do they get there? Well, let's start back at the virus. The virus, as you can see on the left, has little spikes around its surface. Those spikes are what attach to ACE2 receptors in your cells. Not every cell has an ACE2 receptor. So if your cell does not have an ACE2 receptor, that virus will not go enter the cell, take up the cell's machinery, make copies of its cell, and destroy the cell. It's just going to kind of pass on by and never see it and never worry about it. Where do we have most of our ACE2 receptors? Not surprising to us, they're in the respiratory tract, in our lungs, in our heart, etc. So when you hear about side effects from virus, oh, somebody had bad COVID and affected their heart, affected their lungs, not surprising because the virus entered those cells via the ACE2 receptor. It's like a key into a lock. So those little spike proteins then attach, allows the virus to enter the cell, and the virus goes, oh, great, here's some perfect machinery. It hijacks the machinery of your cell, not the nucleus where your DNA is, and it says, please make more copies. Your cell then makes lots more copies of the virus, and here we are on the right side of the screen, number 5, those viruses reassemble inside your cell, and then the cell is dead, it's killed because there's so much virus in there, it breaks apart, and the virus goes out into your bloodstream and looks around for another cell to infect. In the meantime, when your immune system sees this little free-floating virus floating around, it goes, wait a second, we don't want this stuff here. Let's try to take it and kill it so it doesn't enter more cells and kill more cells. So you have these T helper cells, which attach to the viral peptides, and they can come as T cells or B cells. B cells then are programmed to make antibody. The antibody then floats around in your bloodstream and attaches exactly to those little spikes. When it attaches to the spikes, therefore the spikes cannot attach to your cells with that ACE2 receptor, and it's kind of tossed out of your bloodstream and gotten rid of. So depending whether it's cytotoxic T cells, which destroy infected cells, or antibody, which scoops up free-floating virus so it cannot attach to new cells, your immune system is kind of on target, needing both types of immune responses to get rid of virus. Now remember, it's the spike protein that attaches to cells. So if we want to make a vaccine that makes antibody, kind of bypassing steps 1 through 5, and going on to step 6, so to speak, then we want to make antibody to the spike protein. And that's exactly what the vaccines do. There's nothing live about the vaccines. It's purely a way of telling your body, please make antibody against this little snippet piece of the virus. And if you do, we'll all be safe. So here's the original strain of the alpha strain of the virus. And as you could see, it had one finger open, or one part of that spike protein was in the open configuration. What that meant is that the virus had to use its own energy to kind of open 2 and 3 so it could get a good attachment to your cells. Over time, all of these new variants or mutations in the virus have learned to open 2 and then now 3 fingers. So the Delta strain as well as the Omicron strain have 3 open spike proteins, allowing the virus to easily now attach to a cell. And that's what makes it so infective. If you only had 1 spike open, it would be a bit infective, as we saw in the original surge. But now with 3 spikes open, boom, it can easily get into your body and attach to any cell that it wants to because it's ready, willing, and able. Omicron, however, is quite different than the Delta strain. If you look across the bottom of the screen in the blue and the green, you can easily see how the variant Delta arose. It had little point mutations, another mutation, until it finally got to the green Delta that we had in the winter. Omicron, however, took a completely different path. It started off of the alpha strain, and it stayed in that individual, not getting killed by that person's immune system, and grew and circulated and grew and circulated until it had enough mutations to escape and get out into the community. So you may ask me, well, what was wrong with that person? Why didn't they either die from their infection or kill off the virus? And that individual that was the host for the Omicron strain before it got out into the community was an HIV-infected individual in South Africa. They were immune suppressed. They were not on antiretrovirals. And as a result, that virus didn't get killed off, and the patient didn't kill the virus, and it grew and stayed and grew and stayed. And as a result, we have Omicron. Remember, the Omicron was smart, just like the Delta strain was, and that the 3 fingers of spike protein are in the open position, so it can also easily attach to your cells. Remember, viruses are like people too. They want to survive. And the best way for a virus to survive is to be highly infectious, but not lethal. If it's highly infectious and lethal, well, then it burns through the population, kills all the susceptible hosts, and then it's done. It has no place else to go. But a virus that's highly infectious, but not lethal, means that you and I can carry it around and sneeze it out and carry it around and cough it out to the next and the next and the next. And the virus then will sit with us for decades to come. That's part of the worry that people have when we talk about herd immunity. We're on that funny place of the virus is highly infectious, yet not so lethal. So it's going to be incredibly difficult for thinking about how do we get to herd immunity since it's so contagious but doesn't kill off anybody. So this is some data from the CDC that looked at how quickly did the Delta strain take over, and now how quickly is the Omicron strain taking over. If you go back to June of this past year, you can see that we had very little bit of Delta floating around. The Delta is the orange. We had lots of other colors there, meaning that we had lots of other viral variants floating around. All of a sudden, Delta hit, and within a very, very short period of time, it was the majority strain that we saw around the globe. Now, fast forward a couple of months to December, we saw that very, very first snippet of Omicron. And then within 2 to 3 weeks, boom, Omicron then took over. That tells you how much more infectious the Omicron is compared to Delta. And we thought Delta was pretty infectious. Boy, we've learned our lesson. Omicron is so many more times infectious compared to the Delta strain. and it's crowded out every other strain out there. I'm often asked, what about the new strain that's found in this country or that country or whatever country? And the answer is we'll have to wait and see. Is it going to be more infectious than the Omicron strain or less? Because depending on that will depend on whether it crowds out the Omicron strain or not. So this is a slide also looking at cases by age group and then deaths by age group. I often hear, oh, kids don't get COVID, don't worry about it. I'm healthy, I'm young, I'm not going to get sick from COVID. And the answer is those are simply not true. Children, of course, get COVID, and we can see from this data that they represent at least 10% of the population getting COVID across the globe. And when you look at deaths from COVID, you can see while the elderly are responsible for the bulk of patients dying, there's a real significant piece in the 30s and 40s that are also dying from COVID infection. As of December, there were 7.5 million total child cases of COVID reported, and children represented 70% of all new cases, but 20% of the new cases in the past 2 weeks. The week of Christmas, there were 198,000 new cases for an overall rate of 10,000 cases per 100,000 children in the population. I want you to remember that number when we talk about some of the side effects from the vaccines, because people are always worried about, oh my God, there's so many side effects. But look at the case rate, there's 10,000 cases per 100,000 children in the population as of 2 weeks ago. More than 10,000 children have been hospitalized, with 1 in 3 of those hospitalizations winding up in our pediatric ICUs. That's a startling high number when you think of how many new cases we're seeing now. 14 states reported 200,000 plus cases, and 721 children have died across the ages. We've lost 750,000 patients in the past 2 years. When I hear that COVID is not killing patients, the answer is clearly that's not true. 750,000 people have died in excess mortality from COVID than in any other year in the past. What about MISC, or multisystem inflammatory disease? We've had over 5,000 cases, and this number is quite inaccurate because when I talk to my colleagues across the country in the past week or so, they said, oh no, we're seeing a lot more MISC than we ever saw before. And that's a reflection of how many cases of COVID are occurring. Because as you remember, COVID hits, those children are often somewhat sick to asymptomatic, and 3 to 4 weeks later, they develop their MISC, a multisystem inflammatory syndrome. So those cases are first starting to pop up now, and they are associated also with a relatively high mortality. So we are worried not only about COVID now in the children, but we're biting our fingernails thinking about MISC and how much that's going to hit in the next few weeks. So these are the number of cases added per week in children as compared to adults. And you could see there were some times last year in December that kids represented a very small snapshot of the pie. Fast forward to where we are now, the numbers of children relative to adults is increasing, and now they're at least 21% of new cases. What's the problem with this figure? It's very simple. This reports on PCR positivity. It does not take into account at all of those rapid tests you and I are doing in our homes. So if I had to guess, the real number of pediatric cases is more than double, perhaps triple of the numbers we're seeing here, because kids in school who are exposed and sick, those parents are not taking them for PCR testing. They're saying, oh, assume it's COVID, and that kid is staying home. So in summary, there's lots of COVID infections out there in adults and children. Kids are getting sick, they're getting hospitalized, and I'm waiting for the shoe to fall with those MISC cases coming down the corner. And kids are passing it to other kids and adults in their homes because it is so highly infectious. So let's take a break now and talk about the vaccines. Why did warp speed work? We heard all of our legislators talk about warp speed, and people saying, oh my God, it happened too fast. Well, let's tell you how it happened. As an NIH-funded investigator, I was working on TB and HIV clinical trials for women and children around the world. My colleagues were all doing their own assigned jobs. We got the call from NIH saying, stop what you're doing. Only work on COVID. And the assembled brain power not only in this country, but around the world, did exactly that. We did nothing else except work on COVID. And if you can just possibly think about all the brain power that went into that, it's astonishing. People that never would have worked together in the past, all of a sudden sat together day after day, week after week, saying, how are we going to stop this pandemic? And that resulted in people writing clinical trials in a way that we were not accustomed to in the past. Every Monday from 11 to 12, 400 of us got on a conference call to figure out how best to write these clinical trials and roll them out. In addition, when you write a clinical trial, part of it is getting volunteers. Who's going to sign up to roll onto that study? Do they understand the risks and the benefits? Because COVID was so part of our everyday lives in such a horrific way, we had tons of volunteers. At Stony Brook, we were a clinical site for one of the adult vaccine studies. We put out the call, and instantly 500 plus people called us back and said, please, I'd love to enroll on that study. And we enrolled those 500 people in less than 2 weeks on a clinical trial. As part of a clinical trial, you have to understand, while you enroll people rapidly, the big problem is waiting for outcomes. Who's going to get disease? Who's not going to get disease? And is their disease going to progress? Oftentimes, when I've done vaccine studies in the past, it would take us 6 months to a year to enroll, and then 2 years to wait for outcomes, because you had to wait until the patient got sick. Here for COVID, we didn't have much waiting to do because we had so much COVID in our environment that while we enrolled the trial rapidly, patients got sick quite rapidly as well. And in 2 short months after closing enrollment, we were able to look at the data because enough people had gotten sick in those subsequent 2 months after receiving their vaccines. So we had the volunteers, we had the illnesses, and we had people focused on nothing else except analyzing the data. Clinical trials come in all phases. The FDA is very strict about you can't go to a human unless you've done preclinical work in animals. So instead of doing sequential work in one animal model and then a second animal model, multiple labs around the country did in parallel the animal work. One lab would do it on adult animals, one lab would do it on pregnant animals, another lab did it on a different animal model. So all of the dot the I's and cross the T's for all the vaccine trials were accomplished in an amazingly timely fashion because money was available. And again, we all stopped everything else we were doing so that we could get these trials rolled out. In addition, you don't need to prove something works in a child if you've already proven it works in an adult. So knowing that the vaccine trials in adults were successful at preventing hospitalization and death, we were not obligated to enroll another 30,000 or 40,000 children and make them wait for an outcome when we could have been preventing the lethality of the virus. As a result, the clinical trials in children only required about 5,000 patients as compared to the adults that require 30 or 40,000. So let's talk about the vaccines that got rolled out. Well, vaccines come in several different flavors. There's the plain vanilla or protein-based vaccine. There's the somewhat, chocolate swirl viral vector vaccine. And then there's the new funky mRNA vaccine. The protein-based vaccine is the vaccines that you and I are quite familiar with. It takes a piece of the virus, it attaches it to an adjuvant, and injects it into you. Straightforward, easy, no big deal. This is what we have for our tetanus vaccine and what we have for our pneumococcal vaccines and all sorts of other vaccines that we use. You just break off a piece of the virus, attach it to something else, inject it, and hey, good job, make some antibodies. The second type of the viral vector vaccines is a little bit fancier. In this case, an adenovirus, which is a typical virus that you and I see, I want to say almost every day in our real lives. So we have the sequence of adenovirus very, very well described. The adenovirus is then modified so it cannot replicate. It can't do anything else except sneak into your cell. We put a piece of gene from the coronavirus into the adenovirus. We inject it into you. Your body sees the adenovirus, makes that little bit of spike protein, throws the spike protein out of your cell, and your immune system goes, oh, what's that junk? Let's make antibody and get rid of it. And that's how the AstraZeneca and the J&J vaccines were done. The messenger RNA vaccines by Pfizer and Moderna said, we'd like to try something a bit different. We don't want to use any adenoviruses or that old plain vanilla kind of stuff because it takes so long. Why don't we just take part of the code that for spike protein and just snippet that little piece of code off, put it in a nanoparticle and inject it. Great idea, super easy, very cost effective because you could make it quickly. You don't need any fetal cells or any animals or anything like that. You just kind of read the code, attach the little sequence together, put in a nanoparticle, and boom, you're ready. Your body sees that message code for the spike protein. It reads it and says, messages make this stupid little protein, makes the protein, your cell goes, what's this junk? And throws it out. The cell is not harmed. Your DNA, which is really the engine for your human, for being who you are, never gets touched because this is messenger RNA. And once your cell reads that message from messenger RNA, it does like you did in grade school when you got a message. It rips it up. So the vaccine, once it's in your cell, lasts about 6 hours and it's done. There's nothing else. The rest is up to your machinery of your body, which works very well as it does all the time. So now we have 3 different vaccines. We've got the Novavax vaccines, we've got the AstraZeneca and the J&J vaccines, and we've got the Pfizer and the Moderna vaccines. So everybody took a piece in that message RNA that codes for spike protein and did something a little different. As you can see here on the bottom, I've got the entire genome for the SARS-CoV-2 virus. We've got the open reading frame A, first the 1A, then I've got the open reading frame 1B, then I've got that little bit of spike protein message, then I've got some E, N, and M. So if you saw the entire virus, you see this entire genome, and you would be making antibodies to different parts of it. But the E and M's and N's aren't so helpful because that's antibody that you would have made after the virus has already invaded the host. That's kind of closing the barn doors after the horse is out. You'd rather make antibody to prevent the virus from ever entering your cell, and that's the job of antibody to spike protein. Still unanswered is, how many doses do we need? Right now, we're considering that everyone needs a primary series and we need a booster. Will we need a second booster or a third? The answer is, I don't know. And a lot of that will depend on what the variants look like after we've gotten rid of Omicron. We're in the surge for Omicron. We imagine it will last at least another 2 to 3 weeks. Then we'll see the cleanup. Remember, deaths occur 2 weeks after a surge. The MIS-C cases occur 2 to 3 weeks after a surge. So we'll see what happens after that. What about timing? Is it 4 months that you need a booster, 6 months after a booster? And the answer is we really don't know. And the reason we really don't know is that antibody titers tend to go down if you're not seeing new virus. But if you see a new virus or some virus crossing your nose, you'll make some more antibodies. So we really don't know what the right interval is. In addition, we don't know the different intervals for the different hosts. Should an immune compromised patient get a boost at 4 months or an elderly patient at 2 months versus a kid at 8 months? We don't have enough data to give the best timing for the boosters. But certainly looking at some of the data from Israel, now they're on their second booster, seems to suggest that those over 60 years of age in the midst of a Omicron surge are doing much better after they've gotten a new booster. Can we mix and match? Absolutely, we can mix and match. And this is data from a study run by NIH that did exactly that. People got a primary series of one vaccine and then boosted with something else. And showing here quite nicely that if you got a primary series with the J&J vaccine, and then you got a boost with the mRNA vaccine, you made the best antibody response over everybody else. So when people say, I got Pfizer, what should I get next? I'm like, anything else is good. Just go ahead and get your booster. What about side effects? And this is a table looking at the side effects associated with Pfizer. And I've used Pfizer in particular because they already have data presented on the 5 to 12-year-olds. So they considered someone who was older or elderly over 55 years of age. I'm not going to comment on that's real or not, but that's the way they cut the data. And they showed quite nicely that across the ages, dose 1 had less severe side effects than dose 2. Why is that? Because your body is a great immune rememberer, and it says, oh my God, make an immune response. I saw that junk before, I didn't like it. And as part of making an immune response, that's when you feel yucky. You've got the fever, the headache, the muscle pains. Those are all standard accepted side effects after a vaccine, especially when I want your immune system to kind of rev up. What's nice about this data showing that in kids, they actually had less side effects than the older, or rather the younger adults, the 16 to 55-year-olds compared to older adults. What's interesting but not shown on this slide is when the same vaccine studies were used in sub-Saharan Africa, both the younger adults and the older adults had a less side effects reported. Is it because they complained less or Americans complain more? I'm really not sure. I don't know. What are the next steps? Hold on, let me move this over. What are the next steps with boosting? Well, is it the variant or the immune system? Do we really have a better way of making a vaccine? And the answer is we may have other ways of making vaccines. Those are currently under investigation right now. People are working on those, saying that we can't keep boosting every 6 months. It's not realistic. We can't get people to come in now for their 6-month first boost. How likely is it they're going to come in every 6 months? What do these antibody titers really mean? I am often asked, and the answer is they're not helpful. Why is that? First of all, you cannot compare one antibody result from one kit to another antibody result from another kit. So if you went to LabCorp the first time and Quest the second time, and you got 2 different numbers, number A does not in any way compare to number B. In addition, the data that was used to submit to the FDA with regard to titers was an in-house test from both Pfizer as well as Moderna. And neither of those companies has released exactly what they used to measure titers, and they have never been compared to the EUA-approved tests that are out there in common practice. So if somebody says, my titer is 4, and someone else says, my titer is 200, the guy who has 200 is not actually any better than the guy who has 4. The answer is they both made an immune response. That's nice, but I can't say what their antibody titer means in any way. So please don't follow them and check them and follow them, because they're not necessarily helpful. How different are kids from adults? Well, kids' immune systems in general is quite a bit more robust. And that's why the lower dose was picked for the children. Now, looking back, Pfizer has said, actually, we're going to have to boost all the kids at 6 months, and maybe we needed to pick a different dose, because while they looked great at 2 months, at 6 months, their titers are somewhat lower. That data is still cooking. We're going to have to follow the study and see what happens, but no one can make a prediction right now. So let's spend the next few minutes talking about some myths and half-truths. My favorite is vaccination interferes with fertility. When I ask people what that means, I get all sorts of gobbledygook back. So let's unpack it and talk about all of the junk. Well, the first is vaccines are tested in animals to look for fertility and pregnancy signals. None were found on 2 different animal models, and the FDA has seen this data multiple times for both Pfizer, Moderna, as well as J&J. So when I hear it interferes with getting pregnant, the answer is no, it does not. In addition, 35,000 women identified as pregnant received COVID vaccines in this nice paper in New England Journal. There were no neonatal deaths. Preterm births in 9.4% was exactly the same as pre-COVID population, and there was no difference in any outcomes on the mommy side or any outcomes on the baby side. The VSafe reporting system, already looking at over 120,000 reports in pregnancy, has also not suggested any change of fertility or any problems with those women who in fact did get pregnant after they had gotten a COVID vaccine. This is data from Pfizer as well as Moderna looking at adverse events after vaccination in pregnant and non-pregnant women. And as you can see, dose 1, dose 2, for either of these studies, it's a dead heat. There's actually no difference in adverse events whatsoever. I can tell you that one of the things that I was tasked with was writing a clinical trial for pregnant women who got COVID for treatment. That was my sort of niche. That's what I did. We wrote our trial, and when it was reviewed, people were like, oh, pregnant women aren't going to get sick. They're not going to be in the hospital. It's going to take you such a long time to find these women. And Unfortunately, it enrolled within 8 months. And the reason it enrolled within 8 months is that pregnant women, in fact, were getting sick from COVID. They were winding up in the hospital and they were doing quite poorly. And we treated all of those pregnant women to see if remdesivir, which is the only approved drug to use out there, could be used in pregnancy as well. Well, can I report that the data look quite nice? We have a dose for remdesivir during pregnancy. Unfortunately, I can tell you that not a single pregnant woman who entered the study was vaccinated. So getting vaccines during pregnancy absolutely protects you from coming into the hospital. What are some of the other fertility myths? That the vaccine or the antibody attaches to the ovary, and the answer is hogwash. There is no ACE2 receptor on the ovary, so the virus doesn't get there, and the antibody clearly can't get there, and it doesn't attach anyway. So thinking that when you hear something from someone, it must be true, the answer is no, it's absolutely not true. What about this one, my favorite, the vaccine or the antibody attaches to the placenta? When I hear that, I say, oh gosh, you failed 10th grade biology. Why is that? The placenta is made by the baby, not the mommy. So you can give the mommy any vaccine you want. It doesn't cross the placenta. The baby never sees the vaccine. The placenta is a wall. That's how you could have moms that are A positive and have babies that are B negative, and the mother does not get rid of the fetus. That fetus grows quite nicely behind the placenta, even though the mom's bloodstream and the baby's bloodstreams are all attached, because it all goes through that placenta wall, and the placenta very effectively makes sure that none of that antibody that could harm the baby will cross. There is some antibody that crosses at 36 weeks, because that's your body's way of saying, okay, the baby is big enough to survive outside of the womb. Now we have to give it some protection from any infection that it might see. So there's no receptor on the placenta that matches any antibody made to vaccine, and the vaccine, unfortunately or fortunately, does not cross. So when you hear this, you need to shake your head and say, actually, that's just not true. What about male fertility? Now we have a problem. COVID clearly affects sperm. This is a study that was done in men who were 20s. They all had COVID, and they looked at 3, 6, and 9 months afterwards, and there was male subfertility in each of the men who had COVID. Those who had worse COVID had worse subfertility, lasting up to 9 months after their COVID infection. So when I hear a man has been infected with COVID, I can tell you it's going to take a bit longer perhaps for your wife to get pregnant. COVID and vaccination, on the other hand, does not affect fertility. This was a study that was done, again, in men in their 30s who received 2 doses of vaccine, and they looked at sperm counts before and after and several months after the vaccination, and there was no effect in any parameter at all with regard to sperm. So the answer is yes, COVID absolutely will affect fertility. The vaccines, however, will not. What are the next steps then for us? Do we have any current treatments for COVID? And the answer is yes, we have 2 current treatments. Both are oral treatments to be used as outpatients. The Pfizer product called Paxlovid is a quite difficult drug regimen to use. It is a combination of 2 medications that have to be taken twice a day for 5 days. What's the kicker? One of those medications, called ritonavir, is very familiar to those of us in the HIV world because it was the first protease inhibitor we used across the age groups. Having said that, it has multiple drug-drug interactions, and it itself is quite a difficult drug to take because most of the children and adults get diarrhea and throw up. So if you think you're sick with the COVID and now you're taking this medication combination, you may not feel so well. And one of the things you have to do is complete all 5 days of taking it. So if you can't complete it, you won't get the bang for your buck of taking this medication. The Merck drug, while initially looked quite well, has actually not looked so good when the study was completed, and most of us are not using this drug at this time. What about monoclonals? That's the big gamble everyone talks about. Get the monoclonal, you're sick. The initial monoclonals that we used for COVID, the Lilly products and the Regeneron products, unfortunately seem to have no effectiveness against Omicron at this time. And so while hospitals have lots of them on hand, no one's using them because they are not effective. The GSK product is available now. It is effective against Omicron, but the entire state's allotment is the same number of doses that each individual hospital had using Regeneron. So our hospital at this point has 19 doses only, 19 doses for the next month. As you can imagine, that's not going to last very long. AstraZeneca has a new product out there, a combination of monoclonals that is coming hopefully to a hospital near you soon. In pediatrics, we will be a site for AstraZeneca using this combination of monoclonals for children who have COVID. So how do we get back to the office safely? Well, obviously, I think vaccination and now boosting is going to be important for your staff, because with Omicron being so highly transmissible, I expect that people will get infected. But for me, a goal is not to be hospitalized. Right now at Stony Brook, we have over 250 patients with COVID. That includes patients in pediatrics as well as adult and in our ICUs. We expect people to get Omicron. What we want to do is prevent them from coming to the hospital. So vaccination, in particular boosting, is taking a long way to preventing those outcomes. I'm sure Delta Airlines is quite happy now that their name is not associated with it. Does anyone know where the Omicron name is used in a real life? And the answer is, my children told me this. They said, oh, Omicron, we know how to pronounce it. There's the Omicron planet in Futurama. So who knew? But yes, our television series are familiar with all the alphabets that we are now learning. What about flu vaccines and COVID vaccines? You can get them both at the same time with no issue, but you may feel yucky from both of them. So if you're really worried about that and you want to space them out, nothing more than 2 weeks is needed. Go ahead and get your flu shots and your Omicron booster dosing. Well, going back to work, masking does work. Keeping your workplace safe means thinking about lunch breaks as well as other breaks where people will be unmasked and sitting next to each other. Vaccines for all, I think, is going to be something that's very important for you to discuss with your populations. And the rules regarding quarantine are 5 days after you have been infected, and when you come back to work, you must mask, and you can continue to test. What about rapid testing versus PCR testing? I know PCR testing is quite hard to get this day and age, and that's no surprise. It's taking longer and longer for those to come back. Rapid testing was meant to be used in sequence. So a single rapid test that's negative doesn't mean anything. You need to do at least 2 within 48 hours in order to say someone is clearly not infected. However, a positive rapid test, you're done. You have COVID. I've been asked, what about doing the rapid test using the swab in your throat versus your nose? And the answer is no. Please use the rapid test in the way it was approved. That is going to be the best outcome for you for the test. So if you're doing a rapid test and it says saliva, get the right volume of saliva to use. If it says use a nose swab, then do a nose swab, not a throat swab. Thoughts for the future? We all need to work together. It doesn't make any sense to think that what I'm doing does not affect you and what you're doing does not affect me. We're all part of the same community and we have to work together. So in summary, be careful where you read information, talk to your healthcare professional, and above all, remember, we're all part of the same community. So that's all I had for this morning. I've stopped sharing. I think you can see me now. And I'm hoping there are some questions in the chat.
Thank you so much, Dr. Nachman. That was very, very informative and much appreciated. There are some questions. First one, my daughter got the J&J vaccine in April. In November, she had a Pfizer shot. Does she need to get another booster? She is in college.
Right now, we are not recommending a second booster after your primary series and your first booster. Her primary series was 1 J&J dose. Her booster was the mRNA vaccine, and she is perfectly fine and dandy to go to school now.
Okay, thank you. This was my question, actually. What do we look for with MIS-C? And how long after infection, and can it be treated? How is it treated? I have an 8-year-old that had COVID in November, and I have a 12-year-old who is currently in her room with COVID.
So the answer is MIS-C, we typically see a couple of weeks after their original COVID infection. So for someone who's had COVID in the fall, it would be unlikely to the extreme to see MIS-C at this time. However, for all of those kids getting Omicron now, we expect to see a boost or a surplus of MIS-C in the next month, because that will be 3 to 4 weeks after their initial infection. How does it present? It can present with rashes, can present with red lips or red eyes, or swollen hands and feet. But the most important person to ask about any of those symptoms is your child's physician. If your child is acting not well, take a picture, send it to your doc, or do an in-person visit and say, I'm worried about MIS-C, what are the next steps? The reason the pediatrician is sort of the best person to handle the next step is there's so many other circulating viruses that also give you funky rashes and other side effects. So you want to start with the person who knows your kid best and also knows what are the circulating viruses. When we have a child in the hospital with MIS-C, we have very specific guidelines written by experts who tell you exactly what medication to use, how to use it, what to use it, and that will make a big difference in those hospitalizations. So we know how to treat it. We know we'd like to treat it early. So for those children out there who are predestined to get it, I want to say politely, we're ready for them.
Perfect. Okay, thank you. If my children had COVID at Christmas time, both vaccinated, when should they get their booster? My son's college is requiring it by February, but I thought they need to wait 90 days.
So the only reason to wait 90 days is after a monoclonal. The CDC is very, very clear, as in all the vaccine manufacturers. Once you've gotten over your COVID and you're due for a booster, please go ahead and get your booster. There's absolutely no reason in the world to wait 90 days. It's not CDC guidance. It's not anyone's guidance. It's absolutely not indicated at all. So if your child's school requires a booster and they're feeling well after they had their COVID, go ahead and get the booster. I often remind parents, though, if you just had COVID and you're not feeling that well, maybe wait a day or two. Only because if you get a vaccine, you may feel a bit under the weather, and we don't want you to think, oh my gosh, your COVID is back.
Okay, one last question in the chat right now. How much risk is there with an unvaccinated child being around fully vaccinated people?
So if you're talking about risk of acquiring COVID, their risk is 100%. They're not vaccinated, they will definitely get infected. Remember, vaccinated people are also getting COVID. They're getting the Omicron strain because it is so infectious. The vaccine was never meant to protect you against all infection. The vaccine was meant to protect you from dying from COVID, and that is doing quite a great job on. When I look at the data from our institution as well as across the country, 80% of the hospitalized patients are there, they are unvaccinated. In our ICU, it's 100%. So when you think about, is the vaccine working? The answer is it's doing its job. Is it meant to protect you from getting any infection? No, it is absolutely not. So any child who is not vaccinated around adults who are vaccinated, if they're infected with COVID, the child will clearly get infected as well. Will they be sicker than the adults? I don't know the answer, because many of us don't know can't predict which kids will get sick. Unfortunately, we are seeing those kids in the hospital. So the bottom line is, why would I want a child to run the risk of getting hospitalized? I actually don't.
I personally have another question. So I've heard people talk about how as a virus mutates, it gets weaker. So is that true? Can we expect to see another horrible variant like the first time this happened, at the very beginning? Is there any way to know that?
So unfortunately, there's no way to know that. None of our crystal balls work quite that well. People have tried doing the mathematical modeling to say, oh, what happens if we have a mutation here or a mutation there? Is that variant going to be more contagious, less contagious? Is it going to cause more illness or less illness? So the answer is, we expect we'll see another variant, but can I predict whether that variant will be worse for us or better for us? No. But it all gets back to that herd immunity question. And the more people who are vaccinated, the more people who are going to survive. I guess that's good news, but that means the more people that are around to pass more variants around. So the right answer will be in the future, thinking about a different type of vaccine that may protect us not only from the variants we're seeing, but against other parts of the virus as well. We don't have the answer to that yet.
And do you expect to see the numbers coming down now a bit, just based on
So based on some of the modeling that I have seen, we expect that we will see increase in cases for at least the next 2 weeks. By the end of January, we should have plateaued and start coming down. Right now, in some schools, at least 50% of the children are reporting signs and symptoms of COVID. So that tells us that it's getting out there, it's being very aggressive, it's passing to all of our populations. I'm hoping this surge will only last another 2 weeks.
Thank you. Does anybody else have any questions?
I do actually. I had asked a question about the unvaccinated child, but I think it didn't come out correctly. So if a family member everybody in their family has the vaccine, their child who is 9 does not have the vaccine, how much risk is, let's say, if I spend time with that, not my niece, it's my niece actually, like if my sister works with me. So if I'm still working with my sister, what's the risk to me as spending time with my sister when her daughter goes to school and 5 million activities and is not vaccinated?
Well, certainly we expect there is no natural immunity to the virus, so everyone's going to get it. We expect that your niece, like any other child in school, has multiple classmates that have COVID right now, or next week, or the week after.
Right, definitely.
Sort of predestined to get infected. She can easily bring this home to you guys. And you guys will then see virus, especially it's very difficult to wear masks around the house 24/7 when you have other family members living with you. So we do expect that if this is Omicron, that it will be easily transmissible in a household. Unlike work situations where it's only lunch I have to worry about, the rest of the time people are not sitting on top of each other. In the household situation, there are multiple potential places for you guys to get infected. If you are vaccinated, we are hopeful that the vaccine will continue to protect you, like anyone else who's vaccinated, and that you will not wind up in the hospital. Can I tell you that you will not get sick? Absolutely not.
Right. It becomes, my sister works for me.
Right.
I can't afford to miss 5 days of work. So now it becomes, a question to her of why are you not getting your kid vaccinated when you both got vaccinated and the booster? And now as a business owner and also a sibling, I'm at a crossroad because I can't afford to stay home for 5 days, being that I own my own business. And how do I have that? It's a difficult conversation, obviously, when you involve family.
And those conversations, I want to say, are happening at every table around Long Island and New York. And they're happening across the country. And there's no one right answer. And the only thing I remind people is, if you're concerned about fertility, now you have the data. If you're concerned about myocarditis, then we can easily share that data. We need to understand, why is it that after you've had a nail wound infection while you're in the garage and you go to the emergency room, the doc says you need a tetanus vaccine. Nobody turns around and says, oh no, I'm going to go for natural immunity. I'm not going to get that tetanus vaccine. I have never heard of any patient coming into our emergency room who needed a tetanus shot and had that patient say, no, I'm not going to get it. So I need to understand, what is it about this vaccine in particular, recognizing the consequences to yourself and your family, that you are not prepared to take it. Because we have to understand that, and we have to have discussions or conversations about it. And unfortunately, Omicron is much smarter than us. I say that sort of tongue in cheek. The viruses are always smarter than the people. They want to survive. And the only way the virus will survive is if all of us keep getting it and passing it to one another. And schools are the perfect melting pot for viruses. The kids are eating lunch together, they're playing outside together, and they're hanging together in all their after-school activities. So they're predestined to all get it. And as you saw from the data here today, they're predestined to bring it home.
Fun times.
Well, we're dealing with it on a day-to-day basis.
No, I know. Thank you.
Couple more questions just popped in. If I had COVID in November and had the antibody infusion, can I still get Omicron?
Yes, you can. Unfortunately, the antibody that you got in November was either the Lilly or the Regeneron product, and both of those products are not exactly protective against Omicron.
What about the antibodies from having gotten it?
So you probably have at least 3 to 6 months of protection if you had a moderate to severe case of COVID. There's data from Mount Sinai from last year that looked exactly at that. And they looked at how long did you have, quote, protective antibodies after a case of COVID. So for those patients that had a mild case of COVID, by 3 months, those natural antibodies, well, they're just gone. If you had a moderate to severe case, you probably had protective antibodies for about 6 months. That data was then repeated looking in Kentucky. They looked at all the cases of COVID and went back to check who was it the first event of COVID, the second event, and who was vaccinated. And they showed nicely that those who were vaccinated perhaps had one event, but those that were not vaccinated were all on round 2 of COVID. So the answer is yes, you will make protective antibody, depending on how sick you are. That will tell us how long the antibody lasts. But in combination with the vaccination, you're probably in the best shape possible. You've got some natural immunity and you had a boost when you got your vaccine.
And probably around the same, along the same lines, I had a bad COVID infection last spring and recently a breakthrough case of COVID. I'm fully vaccinated and boosted. Will I still be able to become infected with future variants of COVID?
Unfortunately, I don't know the answer, but I suspect it's yes. And that gets back to our idea of how we're going to get to herd immunity if we've all done the right thing. We had COVID, we got vaccinated, we got boosted, but we're still at risk for getting a new variant. And that gets back to, are we going to work on developing a better vaccine or a better strategy? And I don't know the answer to that.
When you talk about having antibodies for a longer period of time, how do you gauge the infection itself? Is it based on hospitalization or how long you test positive or some sort of combination?
We have used a moderate to severe illness, meaning you were hospitalized, as opposed to a mild to moderate illness based on your symptoms if you were home. And unfortunately, it's a little hard to gauge because while I might say, I have a headache every day, I go to work, I don't count that headache. For you, you said, oh my God, I have a headache. It's the worst headache in the world. You get 2 points and I got no points. So it's very difficult to gauge, especially for the outpatient, severity of illness, where I'm used to working through a broken arm, but someone else is going to be laid up in bed with their broken arm.
Okay, I know that we are coming on an hour, so I really do. We appreciate your time, Dr. Nachman. This was very, very informative. Thank you so much for joining us. I know you have probably a million other things to get to, so we want to thank you.
We're getting all of them. Thank you. Thank you so much for inviting me, and I hope the information was helpful to everyone.
It was. Thank you so much.
All right, take care. Bye.
Take care. I don't know if HIA-LI, are you still on?